So thank you for that nice overview. I'm going to shift the gears a little bit and talk about wraparound services, and I'll define it and talk about the implications that this has potentially for rural America. Just as a reminder, I'm Nir Menachemi. I'm from Indiana University and also the on-campus Regenstrief Institute. So what exactly are wraparound services? Probably in its simplest form, they are services that are non-medical, provided in conjunction with primary care. And I will mention lots of studies that I'm going to sort of cover. The vast majority of the studies on wraparound services and how they enhance health or address challenges that individuals have really focused mostly in urban areas. In fact, mostly in federal qualified health centers and inner city urban areas. I think there's a lot to be learned. There are a couple of studies that have looked at wraparound services in rural areas, and I'll touch on them. But keep in mind that the vast majority of these are not necessarily from rural areas, despite the fact that one of my takeaways is wraparound services are probably very beneficial in rural areas. So what are they? Some of the traditional wraparound services involves the work that social workers provide, the behavioral health specialists provide, nutritionists and dietary experts. It also includes pharmacy assistance, patient navigation. More recently, it's included things like financial counseling that can help individuals in a clinical setting get things in their life under control so that they can manage their disease better. And there's also the idea of medical legal partnerships, which really, similarly to financial services, are legal services that help address things in people's lives that they are struggling with that might interfere with their ability to focus and maintain their health. And so these kinds of wraparound services have almost always traditionally been on a referral basis to an outside agency, but lots of federal qualified health centers are co-locating these services with primary care and frequently scheduling the expertise from the wraparound service providers to meet with patients at their primary care appointment, thereby increasing uptake of these services. Now, this is always something that I like to think about. This is from the Kaiser Family Foundation, the image that many of you are probably aware of that describe the social determinants of health. There's lots of different images that kind of describe this, but this one in particular, I think, nicely highlights the fact that almost all of the wraparound services are designed to address one or more of the social determinants of health. Social workers could address things like vocational training or housing issues. Dietitians obviously focus on things related to food, and obviously more than just that. Mental health counselors can deal with things like stress and, to some degree, coping with discrimination and social integration and support systems, and on and on. Each of the wraparound services, and there's really not a complete list of wraparound service providers. They could be anything that could interfere or services that can benefit individuals that could enhance their ability to maintain their health or cope with their disease. And so, in essence, wraparound service providers address or focus, mitigate the effects of social determinants of health. So here are some studies, and this is not a complete overview, but just to give you a smattering that's probably representative of the larger literature. In this study, referrals to social service providers, for example, reduced the need that individual patients reported, or in other words, increased the number of met needs that these social service providers were able to meet. It also increased parents' or caregivers' perceptions that their own kids' health needs were being met. This is a study of wraparound service providers in the form of medical legal partners. This is when pro bono attorneys provide consultative services to people in a healthcare setting. Again, those legal issues might be in the way of allowing that patient to manage their health. Some of the things that medical legal partnerships can help establish are things like adding legal forms to electronic health records to help low-income patients, for example, rectify suboptimal housing conditions. Other examples could be, if someone isn't able to afford their medications for their, son or daughter because of an alimony fight and not having, payments coming. These are the kinds of things that medical legal partnerships can help address, again, with the ultimate goal of helping the patient be able to manage their disease. In this example, this is where mental health, childcare, family services, vocational training, all in the context of substance use disorder treatment clinics, can improve outcomes. Similarly, and this is one of the studies that my colleagues and I published, looking at FQHCs in inner city Indianapolis, where wraparound service providers that included social work and dietitian and patient navigation were able to reduce hospitalizations and emergency department visits in the years following when these services were utilized. And I can go on with lots more studies. I'll show you one or two more. This one focused more on nutritionists and showed how the use of dietitians can improve diet quality, diabetes outcomes, weight loss outcomes, the kinds of things that you'd expect people with this kind of expertise might be able to help assist with. And then this last one really focuses on behavioral health in primary care, and it showed how co-locating behavioral health wraparound services in primary care settings could reduce wait times for treatments, could increase engagement in the care, could increase patient use of needed services, and so on. And so why is there a low uptake of wraparound services? And by the way, the low uptake is not just in rural areas, it's also in many urban areas. And it really stems from this historic fee-for-service incentive structure that really disincentivized wraparound services. These services basically reduce the need for many costlier services later on. And I'm not suggesting any malice here, but the incentives were somewhat perverse, such that most providers and hospital providers were set up to focus on acute issues, not necessarily chronic issues that could be dealt with that involve social determinants of health. And so this bullet here that I have, that average cost savings from that study that I told you my colleagues and I published at an FQHC was about $2 million per year. And that's just for one clinic, and it just involved a panel of about 4,000 or 5,000 patients that we studied. But it's important to mention that under fee-for-service, that savings is a reduction in revenue, whereas under full capitation, it is a true savings to the provider. And so the financial incentives and the reimbursement models really play a role on whether or not to incentivize providers to pursue these kinds of things. Again, most of these have been used with vulnerable groups, in part because the financial model, even under fee-for-service, made most sense for FQHCs and clinics that disproportionately cater to vulnerable individuals, in part because the goal and the mission very frequently is to ameliorate some of these challenges, not necessarily generate revenue. So what kind of implications do these wraparound services have for rural health? In many ways, rural settings might be ideal for wraparound services for many of the same reasons that the speakers before me have already mentioned. The needs stemming from unfavorable social determinants of health is very high. So why not consider ways or figure out ways to integrate the expertise of individuals who specifically mitigate the unfavorable ramifications of social determinants of health? There's a couple of rural studies. This one was in a dental clinic that used the wraparound services of transportation assistance. And not surprisingly, they found that it increased treatment completion rates in rural dental care. But it's important to mention also that this study found that most wraparound services are supported via grants or philanthropy and might be vulnerable when you don't have a lot of resources, and especially when the financial model of delivering care isn't aligned with engaging these services. And then this one wasn't necessarily exclusively in a rural area, but it studied substance use disorder treatment centers and found that rural locations were far less likely to offer wraparound services compared to their urban counterparts. Again, talking about challenges that rural settings have, not only with stigma, for example, on behavioral kinds of healthcare issues, there's transportation barriers. Many of these barriers to wraparound services in rural areas are the same barriers that there is to medical, primary care, and other services as well. And so limited funding, service availability, shortage of wraparound service providers, distance between facilities, and so forth. And so in many ways, I think there's an opportunity here that as we can overcome some of the issues that have historically plagued primary care and dental access, we can also maybe overcome them and figure out a way for wraparound services to play a role in enhancing the care in rural areas. Now, one of the things that was already mentioned, I believe, by Mr. Moore about how decades of advocacy couldn't do what a couple of months of a pandemic did very quickly for telehealth. And so while there's no studies in rural or urban settings, at least not to my knowledge, that have looked at the role of telemedicine and wraparound services, there's a couple of commentaries that really talk about telemedicine as a useful way for dealing with geographic access as a limiting factor. But it might not be as helpful for relieving some of the financial burdens that many of these communities have. And then a very recent, I guess, commentary published in the Health Affairs blog, I think offers a cautionary tale of what financial burdens can lead to. And the last thing I think we'd want to see in rural health is the digital divide becoming even greater as a result of telehealth proliferating, but not as much in rural areas because of financial and other barriers. So I think there's a real opportunity here to think about these things, to talk about the role of wraparound services, and I'm confident it has a role for enhancing rural health.